Today's VetGirl podcast is sponsored by Siva Animal Health, makers of Panaquil CA1. Panaquil CA1 is the first and only conditionally approved innovative solution for the management of clinical signs associated with acute onset of canine pancreatitis. For more information, go to the website at www.panaquil.com.
Hi, VetGirl here today, and super excited to speak with Dr. Chris Keller, fellow emergency veterinarian. And today we're going to talk about all things acute vomiting and diarrhea. Dr. Keller, thank you so much for joining us today.
Thank you very much for giving me the opportunity to be on your podcast, and I'm certainly looking forward to it and hope I can add some relevancy to the practitioners out there. There's something important that they would be able to incorporate as they go forward.
Awesome. Well, just so our VetGirl audience knows a little bit more about you, do you mind giving us a little bit of background about who you are, where you trained, what you do, and where you are now?
Yes, ma'am. So I'm a graduate from Kansas State University in 1982, a long time ago. I was a mixed animal practitioner for about 15 years, mostly mama cows, and did quite a few hogs. We had some small dairies here in Oklahoma. From there, I transitioned to a small animal practitioner exclusively. I was a practice owner, small practice owner. And then I decided I needed to learn about endoscopy and minimally invasive surgery. I trained up at Colorado State at their labs there and brought that back to Oklahoma, and then began to practice in the emergency setting at the Animal Emergency Center here in Tulsa. So that's pretty much it in a nutshell. I've been at it for 42 years, so I enjoy it. I really do. I encourage others to get into emergency medicine because it's we certainly use the help.
Yeah, and it's a fun job because you never know what's going to walk through the door, right?
Absolutely, that's for sure. You bet.
All right. Well, I see we're also both fly fishermen. So I learned in Alaska, but I don't have enough opportunities to do it, I'm afraid. But I love seeing that you do that also.
Yes, ma'am. I enjoy fly fishing. Colorado, there's some state park in Missouri I go to. I've been to New Mexico. It's just a great sport, great way to get out. And I'm also a ballroom dancer, which a lot of people don't believe that when they see me, but that's true. I've been ballroom dancing for 14, 15 years now. So my sons, I have 4 sons. They're on the human side, human medicine, but they don't like me to bring that up around their spouses because they think their spouses want them to get involved as well, which they do. So, but my wife and I, we have a good time doing that. So
that's
a
great.
Good exercise. Yes, ma'am.
You know, it's the best way to survive is to have multiple hobbies, multiple non-veterinary hobbies in veterinary medicine, right?
That is correct. Yes, ma'am.
All right. Well, you and I have both been on the floor, in the trenches, in the emergency room. And so I wanted to talk to you about what I mentioned before, acute vomiting and diarrhea. Tell us how often you see dogs with clinical signs that are consistent with pancreatitis and what seasons you see them.
So we obviously in the ER, we see a lot of vomiting, diarrhea. Obviously, there can be other signs besides of acute onset pancreatitis. But so the frequency is every day. I mean, there's just every day we see signs that can be attributable to acute onset pancreatitis. We also consider, in fact, I considered it so much, they've actually, for the computer at the hospital, downloads the Keller Special, which is a CBC, a Chem 17, CPL, and then sometimes CRP and plus or minus radiographs. Because, with trauma, obviously you can get pancreatitis, acute onset pancreatitis from trauma. Besides the GI signs, we see anytime I have lethargy, the ADR, these dogs that come in, even some of the post-surgery dogs that for some reason are not eating, I think perhaps hypoperfusion is contributing to some acute onset pancreatitis. So to say every day is very true. We see that, and so we always keep that in all the doctors there. We always keep that in our diagnostic rule outs.
You know, I used to always work Thanksgiving when I worked in ER, and I always dreaded it because it was always like the Yorkshire Terrier, the Schnauzer, the Sheltie that comes in that gets like one tiny piece or one lick of turkey, whatever, turkey skin, turkey, whatever. Yep. And they develop those acute onset pancreatitis signs. Now, do most of your acute onset pancreatitis cases come in already diagnosed?
No, They, in fact, of course, in the ER, a lot of our patients come in with other signs. A lot of times it's related to maybe, diabetes, the diabetic ketoacidosis. So some of those signs, those patients present for that. And then we'll go ahead and look for pancreatitis because we've seen obviously an association with it. And so we do have occasionally some of the patients present to us, maybe their primary care is closed or what have you. So those animals will come in and with the classic signs. But honestly, I don't see that many schnauzers. We see a lot of terrier breeds, but we do see large breeds. I don't see very often that prayer position that's, kind of out there that people will say, oh yeah, that's got to be it. But we don't see that. It's almost like it's atypical. A lot of the animals we see is kind of surprising, but we still look for it because I think it's over the years, obviously, since I graduated 82, it wasn't, we didn't diagnose it that much. We didn't know how to look for it, but now the diagnostics have improved. And I think it's what we're finding, and I think you would agree with this in your practice, that it's a much more common disease than what was previously recognized or thought about.
I totally agree with you. It's probably also because, that saying, if you don't take a temperature, you can't find the fever, right? And now we have better diagnostics where, we can diagnose acute onset pancreatitis, where it used to be more of a nebulopathy, right? It was a little bit harder to do.
Yes.
Now, again, I always say during the holidays is when I see the most vomiting diarrhea. Sometimes it's just that, gastroenteritis. Sometimes it can be that necrotizing pancreatitis to the more mild acute onset pancreatitis. So I wanted to ask you in the ER, how many cases of acute onset pancreatitis do you see on average?
On average, I would say that sometimes it seems like we see them all every day, but in all honesty, I would say we probably see 2 to 3 cases maybe per week, to be honest with you. And it's fairly common, and we do look for it. Again, they don't always come in with that, but we find that. We had one here just last week that came in for DKA. We went ahead and checked for pancreatitis, and so we're dealing with both, and those could be pretty challenging cases. But to be honest with you, yeah, I'd say 2 to 3 times a week. We've got dogs that are actually diagnosed with acute onset pancreatitis. Yes, and that's so sometimes a shift. In fact, I was asked that before, and I actually had 3 cases that very day that I was asked how often we see it, and so it's a very common thing that we do see, and I think that in general practice, we're missing some of those, and for whatever reason, not that they're poor practitioners, it's just they're not. I think it's getting out there that it is more common than what we previously thought.
I couldn't agree with you more. And I don't know, this is just my total random VETgirl hypothesis, but I don't know if it's because we see a growing incidence of obesity in our dogs and our cats, and whether or not some of these dogs are getting a lot of table scraps, or whether or not, they're getting additional snacks. But I agree with you. I do think that we see it more frequently. Now, we've already talked a little bit about this, about how acute onset pancreatitis can present a diagnostic challenge, especially if you don't have that, board certified radiologist sitting right next to you ready to ultrasound. The clinical signs that we've been discussing are pretty non-specific, right? Like the ADR, they ain't doing right, the lethargy, the hypersalivation, the painful abdomen, the vomiting, the diarrhea. How do you go from identifying these clinical signs to getting a diagnosis of acute onset pancreatitis? You mentioned some preliminary tests such as, CBC, a biochemistry panel, a CPL. Anything else that you're doing?
So a lot of it is actually a history and physical exam. We take a close look at that. I know I was a rural practitioner as well. And I mean, I know like in Slap Out, Oklahoma or Bug Tussle, Oklahoma, they may not have the diagnostic instrumentation. They may have to send their products or their blood samples to an outside laboratory. So, and for those practitioners, what I would say would, just look at your patient, look for dehydration. Dehydration, if you can just, even a bedside glucose monitor to see if you've got too much glucose. Hyperglycemia is a big red flag, I think, for in the acute onset pancreatitis dogs. And so, of course, the diagnostics in-house, we have, the diagnostic ability to run some samples that actually give us a number where that lipase is. And so we use that, and those are available. I mean, it's relatively inexpensive. It's something that the pet owners can generally afford. And so that's probably the biggest help besides the physical exam and the GI signs. But again, don't fall for the fact that maybe you're not going to, because you don't always, it's always, maybe it's just an ADR. Maybe this dog hasn't eaten for 2 days, no vomiting, no diarrhea, just not feeling well, maybe some abdominal pain. I know some practitioners I've heard are relying on their ultrasound, and I think as a standalone that may not be the best. Again, it can be kind of the one of the things you do, but the diagnostics have improved. There's tests out there, there's machines out there that will help. And for those practices that don't, I think you can be, if you've got a dehydrated animal, go ahead and get some fluids in them at the very least. And then I think at some point, maybe you can start looking at using the Panaquel product if you're pretty sure, because if the other maybe it does have some GI signs and you want to proceed. I think that's a reasonable thing to do. In Oklahoma, the IV catheter, but in Oklahoma, you may be sticking a needle in the blood vein. That's one of the things I learned as a rural practitioner. Wasn't you don't use IV catheters? It's the sharp needle in the blood vein. That's what you do there, and that's fine too. But yeah, so the physical exam, and hopefully you'll have some other GI signs, but the acute onset pancreatitis signs can be other disease entities as well. So you want to keep those in your rule outs. GI foreign body, for instance, we see that, those types of things. So that's what we do there.
Great. That's such an important point, not missing that history, the physical exam, so important. And oftentimes this is undervalued in human medicine, right? Like they get a really quick history. They may or may not do a physical exam, but couldn't agree with you more when I see that. Again, classic signalment breeds that we worry about that are more predisposed to pancreatitis, like the Schnauzer, again, the pot-bellied cushienoid, hyperadrenocorticism patient, that screams pancreatitis. So patient that may be in that prayer position. So again, really important to ask the right historical questions. I've changed the way that I tweak my history asking, instead of saying, oh, did he get into anything else? Or like, did he get into any table food? I also ask the question, did you give anything orally by mouth? Because sometimes they even forget about, other medications or supplements. Now, you already mentioned some treatment for acute onset pancreatitis, such as fluid therapy. But until Panaquel CA1, the standard treatment for acute onset pancreatitis was centered on symptomatic supportive care, right? Fluid therapy, antiemetic therapy, analgesic therapy. And we know that the disease process can be unpredictable and treatment can be challenging. I oftentimes will tell pet owners that the severity of acute onset pancreatitis can really range from mild to necrotizing. Can you talk a little bit about how Panaquel CA1 has added to that treatment plan?
So in our hospital, I think Panaquel, I've been in this same hospital for 7 years, and I actually did a consensus before I came on this podcast and spoke with the other doctors there. And we all came to the agreement that using the Panaquel CA1 shortened the hospital stay, sometimes by as much as 2 days. Previously, a lot of those patients were in the hospital before that product was available. Those animals were in the hospital 5-6 days with symptomatic care. But since we've started using Panaquel, the patients have been able to leave maybe even a day earlier. In fact, now it's a 3-day treatment, once a day for 3 days. So after the second day, those patients are eating, and those patients will come back as an outpatient for that third treatment. The IV catheter is left in, and so they come back. And so that's been the biggest, I think, improvement we've seen by using Panaquel is the shortened hospital stay, and that seems to help offset the cost of the overall treatment, not just for the Panaquel, but for treatment in general. As you know, if you're working in the ER, those overnight hospital stays on fluids and nursing care and all that is expensive. So if you can shorten that time for the pet owner, you've done a great service. And plus the patients are doing well. They're eating much sooner.
That's great. Now, how do you explain acute onset pancreatitis to the pet owner? Any communication tips?
Yeah, so Tulsa is one of the 50th largest cities in the country, which I didn't know that. I looked it up, but that's true. But we serve a lot of rural communities, and so people from all different walks of life come in and they want to know what's going on. And some people obviously want to know all about the cytokine storms and all the inflammation involved, and others just say, how is this going to help me? And I talk to them that it's an inflammatory inflammatory condition. There's a lot of inflammation going on. And so the way the Panaquel works is to help decrease that inflammation. And so the owners, obviously there's some confusion because it's not something they can see. But if you encourage and don't get too far off on, talk about different types of inflammatory cells and all that. But if they understand that inflammation, and then you have to kind of explain to that where that pancreas sits there, the duodenum, and how close it is to the liver and the gallbladder, they seem to get a better understanding. So I go to a little bit of basic anatomy and just show them that location of that pancreas. And if you've got a problem there, you've got a good chance of problems in the surrounding tissues as well. And so that seems to help get that through. And sometimes we'll actually see dogs that come in icteric or jaundice, and that in of itself may be a sign of acute pancreatitis dog. Is acute onset pancreatitis dog is you've affected the extrahepatic bile duct. So I don't go into that with that's why my thought process goes there. So
Yeah, that's great. That is oftentimes, first of all, owners don't detect those signs of icterus until it's really severe and they're like fluorescent yellow. But you're right. Sometimes we do see that extrahepatic biliary duct obstruction. I abbreviate it EBDO, which drives everyone nuts on my medical records. But you're right, that inflammation can be so severe around the pancreas that it really just physically obstructs some of those ducts. Now, any guidance that you are willing to leave us for general practitioners when treating acute onset pancreatitis in their practice?
So for the general practitioners, and like I said, I've been there myself. And so what I would encourage you to do is if you can, is go ahead and if you have to treat them as an outpatient, treat them as an outpatient. Obviously, the more critical ones, obviously you can have a cascade onto systemic inflammatory and multiple organ dysfunction. But for some of the more mild cases, I would say, use your fluids. The analgesics can be something like for pain. And that's one of the things that's pointed out is not all your patients, in fact, only probably half of them are going to really seem painful. But I know from the human studies, they say that over 99% of people are painful. So you kind of have to assume the dogs are painful, but they're fairly stoic. So I would encourage the practitioners to use your antiemetics to treat your dehydration. Go ahead and get that catheter in, which if you're given fluids, that's already there. Go ahead and start Panaquel, give that first dose. And then if you have to refer to the emergency services, then you're already ahead of the game because you've got that patient started. And then for pain management, I think I don't know if we need to get into therapeutics, but buprenorphine, I think that's fairly common. We use a lot of CRIs, lidocaine CRIs for our patients. And again, in general practice, that may not be practical. It wouldn't have been practical in my hospital because we're not there all night. So a lot of it just depends on your patient care, what the patient, where they are as far as how severe the case is. And again, we see patients from all the surrounding states, including Texas, Arkansas, because the practitioners are doing a great job of sending us those patients that they know are more sick than what they can deal with on just a day-by-day basis. But we also see the patients that are treated as an outpatient. If that's the best you can do that. And that's the advice I'd have for them is something that's that simple. Don't get caught up in all the pathophysiology. Just know it can be it's fairly common. It can be a very challenging disease. You're going to have comorbidities oftentimes. So don't get frustrated with that and realize there's maybe some other things. Trying to get that glucose straightened out of the DKA patients is a real challenge. And those are the ones you probably need to refer. I wouldn't necessarily want to fight that in the private practice on a daily basis.
Yeah, that's great information. It is often so amazing having practiced in several urban settings in the United States. Most patients, when they're stable, even if they're really dehydrated, giving them the benefit of the doubt with outpatient therapy, with daily rechecks for a couple of days, some of those patients can do really well. So, as the growing cost of veterinary medicine occurs, just knowing that there's great options out there for treating acute onset pancreatitis, I think is awesome. I also think the important thing is client communication and client education. As the holidays approach, making sure if your clinic has a Facebook page or social media presence, making sure to educate why we don't allow table scraps, why that one piece of bacon could trigger that Schnauzer or that Sheltie or that Yorkie. and just keeping these patients that do successfully respond to treatment for acute onset pancreatitis, making sure that owners know that they should be on a low-fat diet or a no table food diet or no turkey skin diet. So important, just so we can educate them. Dr. Keller, totally appreciate your perspective as an emergency doctor. Love what you do. And thank you so much for joining us for today's VETgirl podcast.
Well, thanks for having me. I certainly appreciate the opportunity to speak with you and the people that listen in on your podcast. Thank you very much.
Thank you.